All right. Good morning, everybody. Nice to see you again. I haven't been able to join many of these last 5 or 6 months because I was helping with a clinic on Wednesday mornings, but someone else has come and taken it over, so I should be able to join a lot more of these, which I'm glad to do. I've enjoyed doing these in the past. So this is a topic I was asked to present about. It's working with people with co-occurring substance use disorders and other mental health disorders. So basically, co-occurring treatment or dual diagnosis treatment, whatever you want to call it. That's me, Hustead. This is R&I where we do not work. We have a smaller building. Most of us who work here, we don't get the cool fancy neurosurgery building, but they tell us to put it in our presentations. It looks nice from the outside. There is a Starbucks in there if people want to go get coffee though. All right, disclosures. I don't have any financial disclosures. I don't work for any companies. I don't get sponsored. I don't have any stock or anything like that. Especially with pharmaceuticals, I really try to stay clear of them as much as possible. I do work at WVU. I'm assistant professor. I see a lot of outpatients. I do research. I try to do teaching sessions when available. Various students. I do a lot with medical students and residents and the fellows and you find people too. So I've treated a lot of people over the years in different levels of care. So whether it's inpatient or outpatient or residential as well, I currently help run the IOP program with Laura Lander, joins us. So a lot of the people that I've treated are more dual diagnosis, so co-occurring disorders, mental health, plus substance use. I also serve as the president of the West Virginia Society of Addiction Medicine. So that's the state chapter of ASAM, if anyone's familiar with ASAM. So it's a pretty large medical society that helps further treatment in the U.S. All right, so some objectives. We're going to try to keep it relatively simple today, but really look at the clinical management of different co-occurring substance use and primary health disorders, mainly the primary health disorders. Determine best clinical practice guidelines and a little bit into also ethical drug testing methods, which kind of goes hand in hand with when we're monitoring people outpatient. So how do we manage co-occurring disorders? So the idea of how they're related to one another, actually there's different schools of thought in how psychiatric comorbidity or mental health issues go along with substance use. So one thought is the so-called self-medication model. So the idea that people have an underlying, say, mental health disorder like, let's say, depression or anxiety, and then in turn they will use substances to try to self-treat themselves. So kind of the mental health leads to substance use. On the other side, you have the disease model where you have the primary substance use disorder, which leads to psychiatric illness. So let's say somebody is drinking a lot and now they develop depression as a result of it. Another way of thinking about it is the bidirectional model. So there's this interplay between SUDs and psychiatric illness. So let's say somebody has some underlying depression, they start drinking, now their depression worsens and they have anxiety as a result. So it kind of goes both ways. Another school of thought is the unrelatedness model. So the idea that there's this co-probability of unrelated disorders co-occurring. So lots of people struggle with alcohol and other substances. Lots of people struggle with depression. There's a percentage of people that can have both at the same time, and they're not really related. There's another one which is the common factor or shared liability model. So this is where you have independent factors affect neurobiological risk of developing both SUDs and psychiatric illness. So let's say somebody's genetics kind of put them at a higher risk to develop both at the same time, or let's say that their upbringing, where they're at, puts them at a higher risk for developing both. Now, really, there isn't one model that describes every person every time. It's really a combination of models. It's ultimately very complex and variable evidence. Certainly, there's patients we've seen that any one of these can really apply to. So we wouldn't really shouldn't subscribe to just one model of it. The reality is that there's a ton of co-occurring disorders between substance use and mental health. So, with that being said, we really do want to caution when we are diagnosing other disorders when someone is actively using. So, we really should avoid diagnosing other mental health disorders that share similar symptoms because we often do see misdiagnoses. I can't tell you how many times we've treated people that we were told, hey, they have bipolar disorder or schizophrenia, and then when we dig down into it, it really is related more to their use disorder. So, for example, if someone is chronically using alcohol or benzodiazepines, which are depressants, invariably they are going to deal with some amount of depression. So you may want to be careful about diagnosing them with depression from the get-go. Another thing would be, let's say you could take the most normal person, give them a ton of PCP and or methamphetamines. Not that I'm saying one should do this, but a thought experiment. So if you do that enough to someone, force them to not sleep for days and days on end, they're going to look pretty manic. So they're going to look like they have bipolar disorder. So we want to be careful about diagnosing that. Other things like synthetic marijuana or high potency THC, this can certainly cause people to look pretty psychotic. So, that can look a whole lot like somebody has schizophrenia. So, first break psychosis. Is this related to substances? Is this more that somebody has schizophrenia and this is their first time that they're showing symptoms? Uh, there is an exception that if substance use has remained stable, so let's say somebody has continued to drink, 3 beers a day for the last 10 years and it really hasn't changed much, but suddenly mental health symptoms develop out of nowhere, you can make a diagnosis of mental health. But this is a tricky diagnosis to make even for professionals. Most of the time, if it is purely a substance-induced disorder, they are likely to improve in a matter of days to weeks after someone stops using the offending agent. So if they're sober, then generally the symptoms go away pretty quickly, but sometimes they can persist for a little while longer. All right, so general approaches to co-occurring disorder treatment. So historically, we treated the substance use first and largely ignored any mental health symptoms. So the idea being that we really needed to get the substance use under control, which we still do, but we kind of put everything else on the back burner, and then we reevaluated down the line if someone was able to string together some sobriety. So we reevaluated if the symptoms persisted when they were sober. Some people will also, unfortunately, ignore substance use. I can't tell you how many times we've had physicians that just, again, totally overlook that someone was, chronically using cannabis or alcohol when they went ahead and made these diagnoses. So that's not ideal either. The current best practices really is to actively treat both the substance use disorder and any mental health symptoms, whether it's a fully diagnosable underlying mental health or if it's more of a temporary substance induced. So the idea being we don't want to just glaze over one, we really do want to try to treat both together. So while we are treating both, the goal really is to identify whether it is a primary mental health disorder versus more that purely substance-induced mental health. Now, it can be challenging, especially in terms of things like psychosis. So there are times where someone can use drugs, say a lot of methamphetamines or cannabis, put themselves into a psychotic state, and then unfortunately, it's kind of tipped the balance that they continue to have symptoms even with sobriety. So it can be very difficult treating both, and you can pretty quickly tell why it takes some expertise in treating these. All right, a bit into trauma and substance use. So this is very common. So it's a common thread that we've found in those who use substances, really regardless of age. Most of you, I'm sure, at this point have heard of adverse childhood experiences, which will reflect the childhood trauma experienced in people. What we often see is trauma will lead to substance abuse, certainly will occur more so during use, and it also perpetuates continued use despite consequences. So you'll see people who have been heavily traumatized as children, they start using. During the course of their use, they continue to experience trauma in various ways, and then oftentimes they'll continue to use, even though they have a great desire to stop using. Rare to see people, regardless of gender or upbringing, not have trauma. So it's just not something we see very often. I mean, we all have trauma to various degrees, but people with some serious trauma, many of the individuals we treat as substance disorders have serious trauma. So what we generally say is if you work with people who use substances, you will encounter trauma. And when I say this, trauma history does not excuse use or condone use, but really it helps with understanding the whole person. So we're not out to say, hey, you've had a horrible upbringing, your use is fine. We're not going to stand in the way of it, anything. But it's to help us understand where people are coming from, and to also give us the option to, if people are willing to get treatment for their trauma, to do so. All right, a little bit in terms of trauma. This is from a paper a few years back. It's pervasive. Most people have experienced at least one serious traumatic event in their lifetime. PTS diagnosis, I would say this is actually an underrepresentation, but it's 3.6% of males and 9.7% of females in the US, so basically 10% of ladies have PTSD, which is wild to think about. The impact of trauma is very broad and touches many life domains. Violent trauma is often self-perpetuating, so the idea that someone who comes from an abusive household is more likely to commit abuse themselves. Trauma is insidious and more likely among more vulnerable groups who already have a higher rates of use. Trauma also affects the way people approach potentially helpful relationships. So, it can be unfortunate that as a healthcare provider or someone that's working in various child protective system or criminal justice system, they may very well try to help these individuals, really mentor them in a way, or just provide the best care. But sometimes they look upon us as almost the people that the figures that maybe perpetuated the trauma to begin with when they're younger. So it can have this weird a transference where they see us in this role as being similar to the people that did them harm when they were younger. So that can be really difficult. The other thing is trauma also affects staff members who work with these people. So this idea of vicarious trauma, I think that one of the most difficult things of this job is to be treating people, seeing people doing really well, and then having bad outcomes where someone relapses and dies or loses a child or whatever it might be. So trauma is something that touches us as well who interact with individuals. A little bit in terms of ACE scores, which I mentioned earlier. So this is kind of interesting, but if you have an ACE score of 0 versus an ACE score of 4, so the higher score being worse, of course, um, you're 242% more likely to smoke. You have a score of 4. 222% more likely to become obese. 357% more likely to experience depression, 443% more likely to use illicit drugs. It's remarkable. 1,133% more likely to use injected drugs. 298% more likely to contract an STD. 1,525% more likely to attempt suicide. It's wild. 555% more likely to develop alcoholism. And then actually, if you have 6 or more ACEs, on average, a 20-year decrease in life expectancy. So we're talking about, instead of living to be, in your 70s, maybe 80s, we're talking more 50s or early 60s. So pretty wild to think about. All right, the Coat Clinic is one of our programs that we have here. It's a pretty large program, the Comprehensive Opioid Addiction Treatment Program. This was actually a article we published about 5 years ago. So in terms of the scores that we see in people that are enrolled in our program. So on a survey of active patients that we had at the time, 54% reported more than 4 ACEs. The mean ACE score was 3.9 across like 500, 600-ish patients that we had at the time. The males, the average score was 3.4. Many had suffered physical abuse. Many males, 11% sexual abuse, tons of them neglect, and also percentage 16% removed from home when they were younger. In terms of females, the average score was 4.5, which is remarkable, very high. Again, I mentioned just some of the last numbers that you see, but 40% physical abuse, 42% sexual abuse. It's almost every other person. 26% neglect, and nearly a quarter were removed from home when they were younger. So just things to put in mind. In terms of PTSD, when we're talking about actual treatment for individuals, and again, the idea being that we are trying to treat the PTSD along with the substance use at the same time. So these are, it's a significant mental health disorder brought on by traumatic experiences. The symptoms that you often see are things like hyperarousal, so people where they're always on edge. Kind of, the classic thing is people who always have to sit in the corner at a restaurant, kind of keep an eye on the door, make sure no one's sneaking up on them. But things like anxiety, depression, mood lability, which sometimes can be confused with bipolar disorder, also sleep disturbances, things like nightmares, nighttime awakenings, fighting in your sleep, like beating your pillow up or beating your spouse up. Generally, we treat with a combination of therapy and medications. So this is certainly a disorder that responds to good therapy. The first line of medications are generally SSRIs, so these are antidepressants. The ones that are approved are things like sertraline, which is Zoloft, and paroxetine, which is Paxil. Other ones that are used are fluoxetine, which is Prozac, and venlafaxine, but many other medications are used. Venlafaxine is Effexor. For things like insomnia, we'll use medications like trazodone, mirtazapine, doxepin, which is an older medicine, and then zolpidem, which is a Z drug. That's Ambien. So we generally try to stay clear of things like that if somebody has a use history, but they can be used. Nightmares, we often treat with actually blood pressure medications, so things called Minipress and Cardura, Prazos, and doxazosin. So the idea being just to familiarize yourself with these things. I'm sure you've heard of many of these meds before. You also will, of course, see that patients often self-medicate with various substances. Some examples would be cannabis is often used for PTSD. The effectiveness varies considerably, and unfortunately, it tends to raise rates of suicide, especially in younger people and veterans, so not exactly ideal. I've also even seen people that had such bad nightmares that they would use stimulants like methamphetamines to stay awake and not go to bed so they couldn't dream. You can't dream if you're never asleep. So it's almost like a Freddy Krueger Nightmare on Elm Street type scenario where people just continue to use so they wouldn't have to sleep and have these nightmares. So people will certainly self-medicate if they have PTSD. All right, anxiety, moving on from something like PTSD to ADHD. All right, so we have to be careful in diagnosing ADHD because many people believe they have ADHD, whether they do or not, up for debate at times. But it is very common in people that suffer with SUDs. Now, with ADHD, technically you have to have at least some of the symptoms start before someone is 12 years old. There's actually three types of ADHD. So you have people that have both hyperactive and impulsivity. So they're just more just the kid is kind of bouncing off the seat at school all the time. So they're hyperactive, they're impulsive. You also have people that are more just inattentive type. So this is what you might hear referred to as like ADD, so people that can't concentrate well. And then oftentimes people actually have a combined presentation where they're kind of impulsive, hyperactive at times, but then they also have great inattentiveness. The first line treatment for ADHD is stimulant medications. So any other medications are considered first line, or excuse me, second line. So the two broad classes we use of stimulants are amphetamine based, which typically is Adderall, Vyvanse type things, and then methylphenidate base, which is the Ritalin. Amphetamines are, as they sound, they're amphetamines. They will show up on drug screens. Something like a methylphenidate, a Ritalin, Concerta type thing, Focalin, will actually not show up on a drug screen. So one thing is when you see a drug screen, it will show amphetamine, but it will not show methamphetamine, generally speaking, when on normal medication. So if somebody is given Adderall or Vyvanse, they should have amphetamines in their system, but they should not have methamphetamines. I mentioned methylphenidate will not show up as an amphetamine because it's not one. Now, I will say that recently we've been talking with folks over in our laboratory testing, and there are a ton of generics now for things like Adderall, even a generic for Vyvanse. So theoretically, during the production process, you can have possible contaminants like low levels of methamphetamines because the chemical structure is not very different from regular amphetamines. So case in point with this would be we've had individuals in clinic and certainly people I've seen in criminal justice where Say their amphetamine level is a 500 or 1,000, which is, pretty normal if somebody's on the good dose of medication for ADD, ADHD, and then they have like a 1 nanogram, really trace amount of methamphetamine show up in their system. So we've seen times where people lost their children over that. And now my suspicion is at times, not all the time, but at times it could be that there could be some contaminants in the products because again, the production process, you will have some meth basically that gets created. All right, second line medications are things like atomoxetine, which is that's Strattera. Another one is guanfacine. Off-label medicines, you may see things like clonidine, bupropion, or even old school medications that we use called TCAs. So once you treat somebody with ADHD, oftentimes the impulsivity and the inattentiveness will reduce dramatically. So if you are able to effectively treat it, people will get better, and generally they'll also show up to their appointments and just be better patients in general. So if you can treat ADHD, it's great to do so with care. In terms of MDD, major depressive disorder, very common for people to have some amount of depression, especially after detox, so not feeling great after they stop using. But depression in and of itself is very common as well. Like PTSD, people are treated with a combination of therapy and medications. There's tons of medicines available now, things like your classic SSRIs, which I mentioned, other things like SNRIs, which are a little bit newer medications, older school things like TCAs, which we will use, but we try to use them with more care because there is a potential to fatally overdose on these, so you won't see us prescribe them too often. There's lots of other kind of newfangled medicines out there that you may see thrown around. Oftentimes, if they're new and expensive, you may see a TV commercial about them. So sometimes you also will see us use things like antipsychotics. So for a long time, Abilify or Piprazole was used. The other one was Quetiapine or Seroquel. So you will see us sometimes use antipsychotics to treat depression. Sometimes mood stabilizers, which are usually more thought of for bipolar disorder, things like lithium and lamotrigine. Other things that are used are things like ECT, so electroconvulsive therapy, and TMS treatment. Other emerging treatments that you see, so some newer things out there that may run into are things like ketamine therapy, S-ketamine that's specifically used for depression treatment. So it's called Spravato. It's a nasal spray. And then you are starting to see more use. It hasn't been done so much clinically, but more in the research world, and could be clinically in the near future, is actually psychedelic medications. So I shouldn't really call them medications. Psychedelic drugs right now, possibly medications in the future, but things like psilocybin, like magic mushroom, which is kind of wild to think about potential applications for depression. Usually, you're not going to see this used. You're definitely not going to see this unless somebody's in some kind of research protocol. But you will see things like ketamine used, especially S-ketamine, if insurances will approve it if someone has very bad depression. Okay. Generalized anxiety disorder, very common and can be a symptom of intoxication and withdrawal. So just in isolation, anxiety is something that happens. Something like generalized anxiety is more considered a pervasive worry or anxiety. You will see people have sleep disturbances, things like panic attacks that arise with GAD. We use a combination of medications, but especially therapy. So therapy in particular is very effective for anxiety. You would argue it's probably more effective than medications in many ways. Particularly things like cognitive behavioral therapy are used for anxiety treatment. Antidepressants are considered typically first line of treatment. Like we had mentioned before, there's another medicine called buspirone that's occasionally used. Treatment resistant, we will sometimes throw mood stabilizers at people or antipsychotics, like I mentioned before with depression. Historically, benzos were used a lot, so benzodiazepines, things like alprazolam, which is Xanax, diazepam, Valium, lorazepam is Ativan, clonazepam is Klonopin. We certainly want to caution the use in people with substance use disorders. They used to be used a lot. When benzos are combined with other medications for addiction, specifically things like buprenorphine or methadone, that can kill someone. So we generally exercise a lot of caution in co-prescribing that. If it's say a one-time prescription because somebody has an MRI or a dental appointment, and they have to take a Valium before their MRI. That doesn't tend to worry us as much, but we generally try to avoid any ongoing prescriptions if we can, except under very special circumstances cases. Alternatives for acute symptoms, so things that we'll use, typically things like antihistamines, you'll see used, or blood pressure medications that can kind of lower people's anxious tone. So there are options that are non-benzo related. All right, another one, bipolar disorder. So what you see with bipolar is episodes of mania or hypomania. So bipolar 1 is mania, hypomania is bipolar 2, but mood swings are often a symptom, but they're not diagnostic of bipolar disorders. So we've had many people get diagnosed with bipolar, again, as a result of having a mood swing or having, substance use, make them look a little weird. Usually with bipolar disorder, the best way I've described it is it's like somebody has a discrete episode as if they're using methamphetamines. So they're not sleeping well, they're really irritable, or they're really happy, they're just acting not like themselves. So it looks almost like somebody's high on meth, but they're not. They're just, it's like their brains just gone haywire for a few days or a week on end. That's generally what we're looking for when we're trying to say somebody's had mania or hypomania. The first manic episode typically occurs in someone's 20s, but it can be earlier, which is rare. So you don't see too many 12-year-olds that have a manic episode or 60-year-olds that have a manic episode. So not something that's very common. It is a lifelong illness, but it is controllable. Mania often requires psych hospitalization. So if someone is really bouncing off the walls, doing impulsive things, we want to get them in the hospital and get them slowed down. When someone is manic, again, they're very impulsive and can look a lot like meth, so can confuse one way or another. So if someone's using meth, they can look manic. If they're kind of manic, they look like they're using meth. Medications with mood stabilizing agents is really first line. Therapy doesn't quite tend to be as effective with curbing someone from getting out of a manic episode. I will say therapy can be pretty effective about things like good sleep etiquette, sleep hygiene, helping people to sleep better to avoid triggering a manic episode. So mood stabilizers you see used are things like lithium, valproic acid, which is Depakote, carbamazepines, Tegretol, Lamictal. Sometimes you see things like topiramate, which is Topamax used. Other antipsychotics medications I've mentioned before are also used in the course of bipolar treatment. Sleep is also, of course, very important. Sometimes we will use things like benzodiazepines, especially in the acute phase. And one thing to point out is benzodiazepines, depending on the benzo that we use, things like Valium can actually persist in a person's system for a week or longer. So we've had times where people were given some medications in the hospital, discharged home, had a drug screen a week or so later and got into serious trouble as a result of medication they had taken in the hospital. So, it's always good to have context to these things. So, all right, last one that we talk about in terms of co-occurring disorders are we call thought disorders, things like schizophrenia or schizoaffective disorder. So these are characterized by episodes of psychosis, which can include positive symptoms, so things like hallucinations, paranoia, or delusions. And the hallucinations usually are auditory in people that have schizophrenia. So drug use can, of course, provoke symptoms, but also unmask a disorder that remains after cessation of use. I mentioned that earlier. The first psychotic break that people experience typically happens in their late teens or early 20s, so around college age. Every year we unfortunately will have a few students that have their first break psychosis when they're starting out college. Dangerousness varies. So if someone is acutely psychotic, they are more dangerous, but in the normal course, they're actually less likely to perpetrate. So the idea being that someone who's had schizophrenia for years is more likely to be a victim of crime rather than a perpetrator of crime. Medication with antipsychotics is the first line of treatment. Therapy also has a role with treatment. So again, I mentioned antipsychotics that we use. Sometimes we use augmenting medications like antidepressants used to treat negative symptoms. So negative symptoms are more like depression, just kind of lethargy, not looking very good, whereas positive symptoms are, again, hallucinations, delusions. It is a lifelong illness. Decline worsens when psychotic episodes occur. So we generally try to keep people on medication, try to keep them off of a bad psychotic episode, lest it basically takes a ding to their brain every time they go into a severe psychotic episode. All right, in terms of treatment pearls, trauma is often, again, a common factor shared by many who use substances. Mood instability and anxiety are common at treatment entry, so not surprising to see somebody who's a little anxious and depressed after they've stopped using. Symptoms may resolve within a few days to a few weeks of stable SUD treatment, and that generally, again, points to it being more of a substance-induced disorder. So symptoms that persist beyond acute intoxication withdrawal are worthwhile targets for treatment. And the goal is, again, to treat disorders simultaneously. Patients treated with medications for opioid use disorder, for example, respond to medications for depression and anxiety at rates similar to those who don't have opioid use disorder. So the idea being that if you do have an individual that has depression and they have an ongoing opioid use disorder that's controlled, you actually have just as much luck getting the depression under control as someone who does not have an opioid problem. All right. It is best to avoid medications that are addictive and or dangerous to combine if possible. Sometimes it's not always possible if someone's in the hospital or they're treatment resistant. Treating both the SUD and the mental health symptoms actually improves adherence to psychotherapeutic and medication treatment recommendations. So the idea is if you are able to treat both things, you're not neglecting one or the other, people are more likely to remain in treatment because you are taking care of the whole person, which is great. All right, a little bit into best clinical practice and ethical drug testing methods. Does anybody have any questions so far? I know we have more time because we don't have a case. Does anybody have anything they want to talk now or kind of wait till the end? I'm not monitoring the chat, so if anybody keep going. Okay. All right, best clinical practice and ethical drug testing methods. So things will change, things have changed. It is, of course, best to follow the most up-to-date evidence-based practices that exist. I would say, especially in these cases where someone has a serious mental health condition along with ongoing substance use, you really should get experts involved. So, really working closely with treatment providers and having consent for open communication. So, if you have an individual that's following with us or somewhere else, trying to get consent so we can talk about their cases. Finding housing and meeting basic needs goes a long way to treating substance use and other mental health issues. So, homelessness, I can't imagine having too great of a mood if I was homeless. And, the idea of being on the streets and always keeping one eye open, lest someone gets attacked or whatever it may be. That's a hard way to live. We had a patient in my one program that, well, they not too long ago, saw somebody get stabbed to death at a shelter. And so you just see, the going back to the idea of this trauma, it really is something that affects people. Just simply putting a roof over an individual's head goes a long way to helping their mental health. Drug screening is an important tool, but it is not infallible. There are issues with drug screens, which we can go over a little bit. And just know that they're imperfect, they're helpful, but they're not the end all be all. So again, seek expertise when evaluating drug screens, but caution when financial involvement. So this is something I preach on that if you have someone who is interpreting drug screens that has a financial interest in somebody continuing to use said drug screen, that's a bit of a conflict right there. All right, best clinical practice on opioid use disorder. So The use of medications for OUD is the clinical gold standard these days. So when I'm using one of the medications that exists, if it's naltrexone or methadone or buprenorphine, beyond just being best clinical practice, I'm sure you're all aware now that there are these protections that exist through the Americans with Disability Act. So this is a major paradigm shift over the last few years. So this was originally in 2022, but the idea that the Justice Department said that specifically people that are on medicine should be protected and be allowed to remain on medications, lest you run afoul of the ADA, Americans with Disability Act. So again, the way they interpret it is addiction is a disability. If someone's prescribed medication, it cannot be just arbitrarily taken away unless someone's abusing it or other drugs at the same time. So that's where people kind of lose their protection. If you're taking a medication, you're taking it appropriately, you can't really be faulted. If you're misusing it, then of course you don't have to, you're not forced to allow someone to remain on medication that they're abusing. In terms of ethical drug testing, it is a powerful monitoring tool used by clinicians and people in law enforcement, of course. Uh, it does provide us with objective information about a patient's recent use and also allows us really feedback about their disease. So if they're improving, if they're struggling at all, we really use it as a tool. Drug testing can also, unfortunately, be used inappropriately, incorrectly, or unethically, leading to potentially some very bad outcomes. This occurs in clinical work, but also, of course, criminal justice work. Uh, what we have seen, this has been a thing that's come up in various clinics, is overutilization of testing for financial gain or misinterpretation is a concern. So this is where there are programs that will just force people to drug screen, multiple times a day when they're in, say, a rehab, and then bill thousands upon thousands of dollars to people's insurance. Is not ideal. There are reasons to order and context to the results. So results in isolation can be misleading. I mentioned, at times there is concern about things like contaminants. Let's say somebody has been in the hospital and they've been given a medicine and, it's still positive a week later. We've seen people get into serious trouble based on not kind of having full facts. Another classic one is, for those unaware, if someone has a seizure in in the wild, so to speak, and EMS paramedics show up, a lot of times they will give people things like Versed, which is a benzo, and then even fentanyl. And fentanyl can persist a while. So we've had people have a seizure unrelated, get some fentanyl by a paramedic. No one really knew about it because the paramedic gave it, and then somebody tests on drug screen a day later, gets in serious trouble. So it's good to be cautious about these things. The other thing, we've talked about this, I believe, in this group, but I've certainly talked about it to individuals, is we have seen these entrepreneurial laboratories that have been selling some weird testing methods. So things like micro blood samples. The sweat patch testing is kind of a question mark, but we don't really look at these as the gold standard of testing. I know there's a lot of money to be made in the testing industry, so we're just very approaching this stuff very cautiously. And certainly, if one of these tests doesn't align with the standard of treatment or standard of monitoring, which is drug screens, usually we'll ignore what these say. All right, screen versus confirmation. This is really important. So we try to avoid making decisions based on the screens alone, which have not been confirmed by the patient, or through the more definitive testing methods. So the definitive testing methods are, sending it out for GC, LCMS. Presumptive tests have significant issues with accuracy, both of false positives, so times where we think a drug is present when it's not, and then also false negatives, which can but should not affect clinical decision making. So, a false positive where we think someone's using and we immediately, throw them out of clinic or incarcerate them, that's not ideal, especially when you get a confirmation. It turns out somebody took some cough medicine that was didn't have, that created a false positive. So we should use presumptive testing for ongoing assessment. So we will continue to use it, but it just, again, be cautious with overuse and in judging too quickly about the results. Definitive testing may be used to detect specific substances, not identified presumptive methods, and to refine the accuracy of the test results. So we generally will use definitive testing. So if a drug screen is not testing for something, and it's something we really want to monitor, we will often send it out for definitive testing. So screening is good and necessary, but again, we avoid making too many major decisions based on the screens alone, unless a patient or client in case admits to use. All right, a little bit more on false positives. We're almost done, I promise. False positives typically occur when our point of care assays, so just your general drug screens, confuse one substance for another, showing something present when in reality is not. Many over-the-counter medications and even prescription medications can cause these. False positives are really considered a worse outcome than a false negative, and the reason being, so if a false negative occurs, so someone tests negative when they're actually using, that really means somebody kind of gets away with something for a little while. When you have a false positive, that means that someone possibly goes to prison or loses custody of a child. So, we not that we like false negatives at all. We want all of our testing to be 100%, specific, 100% accurate, all that stuff. But a false positive potentially is more damaging. So we can, in a way, kind of tolerate more false negatives than we want to tolerate false positives. So we want to be really careful about false positive. So, for example, things like for fentanyl, medications like trazodone, which is a very commonly prescribed medication for sleep, things like Risperdal and Vega, Fanapt, and actually even Benadryl theoretically can lead to a false positive on fentanyl. So, God forbid somebody takes some, Benadryl to get some sleep and then, test positive on a drug screen, or trazodone, which we've seen this happen even in the research world. Somebody takes trazodone and then their drug screen shows fentanyl. So very careful. Some more examples. This is just for your review, but things like dextromethorphan, which is cough syrup, that can show up as an opioid, cough medicine, and certainly show up as amphetamines, very high false positives. Even like a normal antidepressant can show up as a benzo. Naproxen, which I've been taking this week after I threw out my back, and ibuprofen, those are over the counters that can show up as a barbiturate. So again, just being very careful about certain things, not jumping to conclusions too quickly, lest something bad happens. So lastly, cost and ethical concerns. So beware of costs of different testing methods and the financial burden that individual and society will bear in deductibles, copays, or coinsurance needs. It's unethical for physicians or addiction treatment programs to ask laboratories to change cutoff levels to improve the provider's quality metrics. So sometimes what you'll see is where cutoff levels get changed, so they usually will go down, so to try to capture more things. But there's a concern that the lower you make a cutoff level, the higher rates of false positives that you get. So if you make something so sensitive to pick up literally anything, you can actually pick up noise in the process. Another one is unethical to provide or receive incentives for the use of drug testing independent of a clinical rationale. So just drug testing for no reason, that is not advised. And it's unethical for treatment brokers or other individuals to recruit patients into treatment slots or sober living facilities beds with the plan to order unnecessary testing. So we really shouldn't be just testing haphazardly for testing's sake. All right, pearls for drug testing, a little bit. So we screen regularly, but always confirm if warranted before consequential decisions. Many over-the-counter medications, prescription meds will cause false positives. If results are confusing, please get expert help and ideally from a neutral party, so not somebody who has a vested interest in the drug screen used. Be wary of physicians, again, that use kind of that want to overscreen if they have a financial incentive to do so. And again, as clinicians, we more try to use drug testing as a guided treatment, not always as a punitive measure. So in terms of clinical work, if a relapse happen, which they do happen, we try to work through them. So we don't necessarily try to throw the book at everybody and kick them out of treatment. Outcomes do improve significantly when detection of substances use is likely, and participants receive incentives for abstinence and sanctions or treatment adjustments for positive test results. So if you're incentivizing people to be sober, that's good. If the sanctions aren't kind of too harsh, where we're not tossing people away or immediately taking someone's kid, that can actually also spur them on to better abstinence. So, in conclusion, substance use and mental health disorders affect many individuals. Treating comorbid mental health issues is complex. The goal now is really to treat the disorders simultaneously. Best practices can and will change, and thus should be closely monitored. Things like, again, using medications, even in prison settings, that's a huge change over the last 3 years. Drug screening is a powerful tool that must be carefully interpreted. Ultimately, patients will improve when provided appropriate care. So most people will get better if you give them a chance, which we try to do. So does anybody have any burning questions? I also have contact information, and for those who've ever called before, we are more than happy to assist, especially when you have weird situations, tricky drug screen results, things that look off. We do try to help when we can. So.